Hello everyone and welcome back. So we have discussed the first two topics, that is the endometriosis and the ectopic pregnancy, in the first video of today's topics. Now we are going to discuss the UV prolapse and the infertility in this section. We have started the series and we will complete this sessions of gynecology subject in 8 videos, that is 3 days. So coming towards today's topic, that is contraception. Okay. So, UV prolapse, sorry. I will discuss the contraception topic in a separate video as it is a little bit lengthy topic. Okay, so UV prolapse, we are having a scenario that there is a 38 years old P5 presents with 2 degrees UV prolapse. What are the differential diagnosis, the causes, the management? And another scenario is that there is a 3rd degree prolapse. So what is the management? Then the scenario is that there is a present perineum. So what are the risk factors, the role of vaginal pessaries, the merits and the demerits, and define the 3rd degree prolapse and investigations. So the differential diagnosis of UV prolapse is that the all types of prolapse: cervical polyp, chronic inversion of the uterus, swelling in vagina, uterine fibroid, and cervical fibroid. These are the differential diagnoses of the UV prolapse. The definition is that UV prolapse is defined as protrusion of the uterus or vagina beyond their normal anatomical confines. Then vaginal prolapse and uterine prolapse. We have cystocele. In vaginal prolapse, we have cystocele 2 and 3, and the urethrocoele is 1 by 3, and cystourethrocoele, and the posterior rectocele is 2 by 3rd, the enterocele is 1 by 3rd, and the wall prolapse is present. So these are the prolapse. The 1st degree prolapse is the uterus has descended from its normal position but still lies in vagina and nothing appear outside the vagina. And the 2nd degree prolapse is that uterus has descended to level where cervix appears outside introitus while body of the uterus lies within the vagina. Then we have 3rd degree prolapse, which is the extreme form of UV prolapse where whole uterus lies outside the introitus, commonly associated with cystocele, enterocele, and rectocele. The 3rd degree uterine descent, also called procedentia. Then we have 4th degree procedentia is when cervix and uterus both lie outside the introitus. The supports of the UV prolapse are pelvic ligament, cardinal ligament, uterosacral ligament, round ligament, pubocervical ligament, posterior pubourethral ligament. And the muscles are levator ani muscles, pubococcygeal and uterococcygeal. The causes of muscles, these are the muscles, and posterior pubourethral ligament. The causes are multiparity and menopause, raised intra-abdominal pressure, that is chronic cough associated with asthma, and chronic bronchitis and TB. Then we have obesity and chronic constipation. Then we have occupation involving heavy weightlifting, congenital weakness of the pelvic floor, birth trauma, surgical trauma, and hormonal factors. These are the causes of the UV prolapse. The complications are hypertrophy of the cervix, that is the elongation of the supravaginal cervix, the congestions and edema, and the glandular hypertrophy. Ulcers are the complication, incarceration, keratinization, and urinary tract complications, which are the frequency of urine, the stress incontinence, the urinary retention, the urinary tract obstruction, the urinary tract infection, and the urinary calculus. The clinical features are something coming out of the vagina: stress, incontinence, and frequency and urgency, backache, pelvic pain, coital difficulty, perineal heaviness, dragging pain, and bleeding, and perineal discharge. Investigation options are examination, that is GP, which is old, obese, diabetic, maybe hypertension, maybe pulmonary disorders like asthma and chronic bronchitis and TB. Then abdominal examination, which is chronic constipation and abdominal mass and ascites. Then pelvic examination, which is inspection of the external genitalia, the speculum examination, and the bimanual examination. The clinical examinations are clinically examined, no investigations for confirmation of the diagnosis. Urinary is done for urinary tract infections. And urodynamic studies are done, which is bladder dysfunction and urinary incontinence. Ultrasound is done for fibroid and ovarian cyst. Renal function tests are done for blood urea and creatinine. And radiological investigations are done, that is intravenous urogram, urinary tract, chest x-ray, and pulmonary structures. And the urine test to routine tests are done, which are FBC, blood group, sugar, and ECG. The management is that the counseling is done of the patient for ectopic UV prolapse, that is counsel that prolapse cause no risk to live alive until this is urinary obstruction, and future childbearing must discuss with the patient. It is better to complete family before surgery for UV prolapse and inquire about the coital activities. The prevention is done, that is antenatal care is provided, postnatal exercise, care in the labor, hormone replacement therapy, family size, and aggravating factors. The treatment options are: treatment depends upon the age, the parity, the future wish for the child, the severity of the disease, extent of the symptomatology, and the concomitant urinary symptoms. The medical treatment is that the general care is provided, that is for obese to lose weight, the treatment of cough and the constipation, and the treatment of the ulcers. Now, for first degree prolapse, surgery not needed. If complications are also not there, give symptomatic and palliative treatment. The treatment is for urinary tract and local infections with antibiotics and anti-inflammatory drugs. If predisposing factors like chronic constipation and chronic cough are present, then treat them as well. Advise the diet and control and exercise for the obesity, and explain women to avoid lifting heavy weights and laborious household work. Then the reassurance of the couple is done for the first degree prolapse. That is, advise diet and ask them to follow given diet. Encourage her to have balanced and high protein diet to overcome nutritional difference and build up depleted stores. Then 2 degree and 3 degree prolapse, advise surgical treatment, that is Manchester repair. Advise such patient to complete the family as soon as possible, as further deliveries may again cause prolapse. If family is complete, then counsel her for Manchester repair. The Manchester repair is a preferred treatment for UV prolapse. Patient is young. Patient wants to have more children. Patient wants to conserve her uterus, and patient is unfit for prolonged uterus. The 4 degree prolapse for vaginal hysterectomy is done, and the role of pessary is that the patient who is unfit for surgery, it is used in those patients, for pregnant patients, and for old who is hypertensive and diabetic. Once inserted, it should be against the uterus, while cervix should be in middle. Call back patient every 3 months for change of pessary. Then, if size of the pessary is increased, excessive discharge, roughening of the skin of vagina, and ulcer necrosis can occur. If size of the pessary is decreased, it will be extruded out. Then, at the time when women forget to remove pessary, normal tissue grow, it gets hidden, then it's removed under anesthesia. And the indications for pessary are that patients who are unfit for surgery, patient waiting for surgery, patient unwilling for surgery, and patient who desire for more children. So we have discussed the topic, the UV prolapse, that there is a 38-year-old P5 present with 2 degree UV prolapse. So what are the differential diagnosis, the causes, the management, and then the scenario is that pressure perineum is present. What are the risk factors, and define 3rd degree prolapse. What is the role of vaginal pessaries? What are the merits and demerits, and what is 3rd degree prolapse? So these are the differential diagnosis of the UV prolapse. Cervical polyp, chronic inversion of the uterus, swelling in vagina, uterine fibroid, and cervical fibroid. This is the definition. The UV prolapse is defined as protrusion of the uterus or vagina beyond their normal anatomical confines, and it is vaginal prolapse and uterine prolapse. And then we have first degree prolapse, that is the uterus has descended from its normal position but still lies in vagina and nothing appears outside the vagina. Then we have second degree prolapse, which is the uterus has descended to level where cervix appears outside introitus while body of the uterus lies within the vagina. Then we have third degree prolapse, that is the extreme form of UV prolapse where whole uterus lies outside introitus and commonly associated with cystocele, enterocele, rectocele, and third degree uterine descent, also called procedentia. Then we have fourth degree procedentia is when cervix and uterus both lies outside the introitus. Then the supports of the UV prolapse are pelvic ligament, cardinal ligament, uterosacral ligament, round ligament, pubo-cervical ligament, posterior pubo-urethral ligament, and the muscles are levator and eye muscles, which is pubococcygeal and iliococcygeal. Then the causes of the UV prolapse are multiparity, menopause, raised intra-abdominal pressure, chronic cough associated with asthma, chronic bronchitis and TB, obesity, chronic constipation, occupation involving heavy weightlifting, congenital weakness of the pelvic floor, birth trauma and surgical trauma, and hormonal factors. The complications are hypertrophy of the cervix, which are elongation of supravaginal cervix, congestion and edema, and glandular hypertrophy, and the ulcer, the incarceration, the keratinization, and the urinary tract complications, which are frequency of urine, stress incontinence, urinary retention, urinary tract obstruction, urinary tract infection, and urinary calculus. The clinical features are something coming out of the vagina, stress incontinence, the frequency and urgency, the backache, pelvic pain, coital difficulty. The investigation options are examination, that is GP, then abdominal examination, pelvic examination, then clinical examination, urine RE, then the urodynamic studies, the ultrasound, the renal function test, and the radiological investigations, and the routine investigations. Then we have the management options, which is first one is counseling, and then the prevention. The treatment is specifically for the each degrees. The medical treatment is the general care, and for first degree prolapse surgery is not needed, and reassurance of the couple is done. Then for 2 degree and 3rd degree prolapse, it is surgical treatment is advised, and Manchester repair is done. Manchester repair is the preferred treatment for UV prolapse, and patient is young. Patient wants to have more children. Patient wants to conserve her uterus, and patient is unfit for prolonged uterus. So for these kinds of patient, Manchester repair is indicated. For 4-degree prolapse, you will do the vaginal hysterectomy, and a roll of pessary can also be used. This it is used for the patient who are unfit for surgery, who are pregnant, who are hypertensive and diabetic. Once inserted, it should be against the uterus, while cervix should be in the middle, and call back patient every 3 months. Pessary is changed after 3 months. If size of pessary is increased, excessive discharge, deafening of skin of vagina, ulcer, necrosis can occur. If size of pessary is decreased, it will be extended out. At time moment, forget to remove pessary. Normal tissues grow, it's go hidden, then it's removed. Indications of pessary are patient unfit for surgery, waiting for surgery, unwilling for surgery, and who desire for more children. So we have discussed here the merits and the demerits of the pessary. So this was the topic, the UV prolapse. Now we will discuss the topic infertility. Okay, now the second topic is infertility. So we have a scenario for infertility is that there is a 22 years old lady with primary infertility came to OPD. How would you manage her? A couple has primary infertility of 2 years. So what are the investigations, the management options? Then define infertility. What is primary infertility? What is secondary infertility? Then what is the scenario? Another scenario is that 25-year lady with primary infertility presents with multiple fibroid on ultrasound. What is the treatment and what is myomectomy? Another scenario is that a P1 with history of instrumental delivery for the prolonged labor and puerile and discharge after delivery. She is complaining of inability to conceive. Her husband lives with her and she has regular menstrual cycle. So what are the causes of the infertility? The investigations that prevent the complications, the treatment, and the questions asked in history. These are the important questions that are asked about the infertility. So let's define what is infertility. It is the failure of couple to conceive after 1 year of regular and unprotected intercourse. And the types are primary infertility, which are never achieved conception before, and the secondary infertility, which is who failed to conceive after conceiving one or more. Now the causes of infertility are both the female causes and male causes. The female causes are failure of ovulation, that is gonadotrophin deficiency, polycystic ovarian disease, ovarian follicle, hyperprolactinemia, weight changes, environmental factors, and drugs. Then the tubal factors are PID, that is pelvic inflammatory diseases, endometriosis, tubal surgery, rupture appendix, ulcerative colitis, and Crohn's disease. Then the cervical factors are reduced amount of cervical mucus and anti-sperm antibodies. Then the uterine factors are multiple submucous fibroids and intrauterine adhesions. In male, the causes are low sperm count, that is pituitary gonadotrophin deficiency, impaired testicular functions, conduction system defects, and improper semen collection. Then the reduced motility, that is temperature, infection, and anti-sperm antibodies. Then the morphology is varicocele, bacterial and viral infections, and drugs like nitrofurantoin, and the reducible volume, and the coital problems, which are low coital frequency and impotence. These are the important causes of the infertility in the male. Now the history questions that are asked from the female is that age of the female after 35 years the fertility chance decrease. Then the duration of the infertility, whether primary or secondary. Then the duration of the contraception used, and the length of the marriage, and the coital frequency and postcoital bleeding. And the menstrual history, that is it is regular or cycle length, duration of contraception, length of the marriage, coital frequency, and postcoital bleeding. Female occupation, menstrual history, that is the regularity, the cycle length, the dysmenorrhea, the history of oligomenorrhea, the history of intermuscular bleeding. Then do they live separately for a long time? Then what is the past history, that is any TB, diabetes mellitus, drug history, previous surgery, and sexually transmitted diseases, smoking, and alcohol. Then obstetric history in case of secondary infertility, history of PPH, endometriosis, and ENC, puerperal pyrexia, abortal sepsis, intrauterine contraceptive devices, hot flushes, galactorrhea, and abdominopelvic surgery. Now the male is the age of male, the fertility chance, and the poor semen analysis, the coital difficulty, the occupation, the sedentary habits, and the exposure to radiations, the past surgery or herniorrhaphy, orchidopexy, or vasectomy. Then the medical history, which is include the history of infections, for example, mumps, gonorrhea, and genital TB, the history of drug intake, trauma, and torsion of testes, the frequency of the coitus, knowledge about fertile period, and premature ejaculation and impotence. These are the questions that should be asked from the male. Now examination is done for both the male and the female. So for female, examination is that GP is done, that is weight, blood pressure, anemia, pulse, temperature, height, obesity, acne, hirsutism, secondary sex characters, breast for galacturia, abdominopelvic mass, endocrine disorders, and breast examinations. And then the systemic examinations are done, which are all system, especially abdominal examination. Then bimanual or pelvic examination is done, that is the state of the hymen, the infections, that is PIDs, vaginal septum, and position of the cervix, uterus, and any tenderness. And then for male, GP is done, that is general appearance, weight, and blood pressure, external genitalia is checked, and the size or any abnormality, that is hypospadia, scrotum for testicular size and consistency, tenderness, and varicocele. For groin region, examined for scar, marks, any lumps suggestive of undescended testes. Now the investigation options for female are that ovulation detection is done, that is hormone assay, ovarian ultrasound, basal body temperature chart, endometrial sampling, and cervical mucus test, which is spine basket test and fun test. Then we will do the tubal factor, that is laparoscopy, hysterosalpingography, ultrasonography, salpingoscopy, and philosophy, and Rubin's test, that is dilatation and insuffocation. Okay, uterine features are checked, cervical factors are checked, that is postcoital test, and TFTs, LH, FSH, and prolactin is checked. In male, semen analysis is done, hormonal assay is done, chromosomal analysis, testicular biopsy, and sperm antibodies, and semen fructose. Investigation in both partners are in vitro mucus penetration test and sperm penetration test and sperm cervical mucus contact test. Now the treatment options for female and male are separate. The reassurance of the couple, the general health improvement in the correction of the dietary habits, the decreased weight, the hygiene, the improved HB level, and the treat infections are both common for the male and female. Now specifically in the female, for the induction of ovulation, clomiphene is used, which is given for 5 days and started at the second day of menses. Tamoxifen is used, which is 5 days 20 mg per day, and cyclophenol is used, which makes the cervical mucus thin and elastic, and bromocriptine is used, which is used at any day. It is 2.5 mg per day. Gonadotrophins are used, that is human menopausal gonadotrophin, luteinizing hormone plus follicle stimulating hormone, and gonadotrophin releasing hormone analogs are used. The tubal factors are characterized into anastomosis, salpingostomy, tubal reimplantation, salpingolysis, and uterine cervical factors. In the male specifically, the alcohol reduce and smoking is prescribed. Hypogonadotrophic hypergonadism, increased sperm count, dated HCG 2000 IU once or twice weekly for 6 to 12 months is given, and sperm antibodies, prednisolone 20 mg per day 1 to 10 and 5 mg on day 11 to 12 for 6 months is given. Genital tract obstruction, that is reconstructive surgery of the visa differentia is done, correction of the varicocele is done, and coital functions improvement are done. The treatment of unexplained infertility is that intrauterine insemination is done, in vitro fertilization, gamete intrafallopian transfer, zygote intrafallopian transfer, and microsemination technique is done. Okay, so we have discussed the topic infertility. So first of all, we have discussed the scenario for it. Then we have discussed that what is infertility. Then we have discussed the causes, which are both the male causes and the female causes. The female causes are failure of ovulation, tubal factors, cervical factors, and uterine factors. In the male, these are low sperm count, reduced motility, morphology, reduced volume, and coital problems. Then the history questions are for both female and male. So these are the questions that we have already read, that the following questions should be asked from the female, and there are different history questions for the male. So these are the questions. Then we will do the examination both for male and female. For female, first of all, GP is done, then the systemic examination is done, then the manual or pelvic examination is done. In male, the GP is done, and the groin region investigation is done. Okay, the investigation options for female are ovulation detection and tubal factors and uterine factors, cervical factors, and function test. In male, the semen analysis is done, and the hormonal assays is done, chromosomal analysis, testicular biopsy, and sperm antibodies, semen fructose. And the investigation in both partners are in vitro mucus penetration test, sperm penetration, and sperm cervical mucus contact test. Then the treatment options for female and male are different. In these are the common treatment options, and the female induction of ovulation is done, and tubal factors are corrected. In male, the alcohol and smoking should be reduced, hypogonadotrophic hypogonadism, and sperm antibodies, genital tract obstruction, correction of varicocele, and coital functions improvement. And then we will do the treatment of unexplained infertility if the reason is unknown, that is intrauterine insemination, in vitro fertilization, gamete intrafallopian transfer, zygote intrafallopian transfer, and microsemination technique. So this was the topic infertility. In the next video we will discuss the contraception. Contraception is a little bit lengthy topic, so we will discuss it in a separate video. Thanks for watching, and don't forget to like and subscribe my channel.